I do want to move on to our next speaker of the afternoon. Dr. Christian E. Machado is the Director of Cardiac Electrophysiology and Cardiac Rhythm Management Device Clinic at Providence Hospital. Dr. Machado specializes in electrophysiology, including pacemaker implants, ICD implants, and ablations. He is a nationally and internationally known speaker on the subject of cardiac pacing and electrophysiology. And his topic today is the evolution of radiation protection. So please help us welcome Dr. Machado.
Thank you very much. So I have the challenge to keep you awake after lunch, I guess. So I'll try to speak like an espresso. So I would like to thank the organizing committee for inviting me to have the opportunity to discuss this important subject, which is very fashionable right now. And I'm not sure that I am an expert on radiation or radiation protection. So I was wondering why I've been asked to speak on this subject. I figured that some of the organizing members of this event probably visited my Facebook page and recognized that, let's see, this is not working. Next slide, please. Sorry, that this is what my offsprings look like, and maybe the recognition that I've been exposed to radiation for too long makes me an expert on this subject. I'd like to go over quickly what are the subjects that we're going to be discussing quickly today here. I'd like to review some of the history of radiation in cardiology. How does radiation affect the living cells and causes health hazards? Classification of the adverse effects of radiation. We'll talk about the determinants of radiation in the electrophysiology and invasive lab. We'll talk also quickly about the current status of radiation protection. We'll try to predict where the future is going. And if we have time, we'll talk about my personal experience in the EP lab as far as radiation protection is concerned. So when we talk about history of radiation, we have to talk obviously about the physicist Wilhelm Conrad Roentgen, that in around 1895 discovered obviously X-ray technology and was very much a revolutionary scientific finding. In that era, within a year of the discovery of X-rays, actually we begin to see reports of radiation effects on skin and eyes. We actually see in 1899 the development of the first commercial fluoroscope by Thomas Edison. This is what I call the pioneer era. And then we see actually many of the physicists aware of these side effects of radiation, shying away from the investigation with X-rays, and even Thomas Edison being quoted as saying that I don't want to talk about X-rays, I'm afraid, after his assistant, Clarence Daly, who actually was passed due to the results of acute radiation exposure. We cannot finish talking about this era without paying a tribute to Dr. William Rollins, who was a dentist and was probably the pioneer in developing radiation protection with the inventions of lead tube housing and collimators. The next era is the dormant era, an era that efforts are concentrated on expanding the applications of X-ray and making X-ray more powerful and unmatched by radiation protection, unfortunately. This leads to an organizational era, an era that is characterized by trying to standardize radiation protection, and guidelines are actually implemented to reduce radiation exposure in the interventional lab. If we concentrate on the history of X-ray in cardiology, we can go back, I would say, three major events. In 1953, first non-selective angiogram by a Portuguese group. In 1960, development of a first coronary angiogram by Dr. Soanes in Cleveland Clinic. And in the early 60s, reports of the first pacemaker implants with fluoroscopy-guided technology in United States, France, and Sweden. So the landscape has changed tremendously, and this has to do with the fact that obviously we have more complex procedures that are requiring more fluoroscopy time and more time in the lab. And if we look at this slide, we can see that on your left-hand side, the number one contributor to radiation burden in the U.S. population were at the time radon, and with only a 15% contribution coming from the medical field. And that changes in the year 2006, when now radiation coming from the medical field becomes pretty much 50% of the radiation burden in the U.S. population. And to put it into absolute numbers, I don't know if you can see from back there, but the per capita per year medical radiation exposure in the 80s due to medical radiation was equivalent to 0.53 millisieverts. And in the 21st century, that figure has gone up to 3.0 millisieverts. To put it into perspective, the equivalent of 15 X-rays per year. So the current problem is that interventional labs contribute 50% to all medical radiation, ionizing radiation exposure. Physicians and staff are often poorly or partly trained in the use of radiation safety techniques. Average work hour for an interventional cardiologist is approximately 8 hours. Out of those 8 hours, 10 hours out of those 8 hours are usually wearing lead. There is obviously a significant occupational hazard when we're talking about increasing our hours wearing heavy equipment, heavy aprons, and actually being exposed to high doses of radiation. This occupational hazards can be thought of as increased cancer and orthopedic injury. There's no doubt that there is a clear association between ionizing radiation and brain tumors. It's one of the few well-established causative agents. So try to explain to you the effect of radiation in a living cell. Ionizing radiation removes an atom, forming an ion, and this ion reacts with other atoms, causing cell damage in many ways. I have a slide here, hopefully will project well, an animation, how direct damage occurs to the chromosomal components with ionizing radiation, breaking up the nucleic acid, and obviously causing rearrangement or disruption of the nucleic acid in the DNA, leading to mutations. Also, there is indirect effect radiation via, for example, changing the molecular structure of water in the cytoplasm. Ionizing radiation, obviously, doing so by creating ions, the ions reacting against each other, and then converting water into toxic substances with free radicals. So a low dose radiation like the one we received every day, 360 millirems per year, it would be normal background radiation. Cells can repair and without any damage. A medium dose radiation, like 100 millirems, the cells can repair but with permanent damage. And this changed cell obviously would have genetic mutations that will become carcinogenic or cause hereditary diseases. A high dose radiation or acute radiation, for example, 1 gray, will cause the cell to be destroyed. No repair will take place. Organ failure would follow, and radiation sickness would be a great example of this. So we'll change gear a little bit here and talk about the classification of adverse effects of ionizing radiation. The two most common ones, or how we classify them to understand them better. We have deterministic effect, which is a predictable and dose-related and achieves, once you achieve a threshold, any tissue or any patient exposed to that threshold will have obviously a detrimental outcome. For example, skin injury, which is the most common side effect or detrimental effect of radiation, fluoroscopy radiation. Also hair loss and lens injury. The more difficult to actually associate is the stochastic effects, because these are effects that occur not within 4 to 6 weeks like the previous effects I described, but this occurs 5 years down the road, 20 years down the road. So it's more difficult to actually lead to a causation effect. This is probabilistic in nature. Clear examples are solid tumors of the brain and heritable genetic defects. So what are the determinants of radiation in the lab that we work every day? Well, there are equipment related, which I will go very quickly, patient related, also I'll just touch on that, and then we'll spend more time talking about physician conduct related factors. So obviously equipment related, all kinds of things that you can do to your equipment to reduce the dose exposed to patient and your staff, collimation, maintenance and calibration, etc. Patient-related issues have to do with patient's weight and body habitus. Obviously, the bigger the patient, the less penetration, the more attenuation, and the more scattering radiation you will have. Physician conduct, things that are within our control to reduce radiation exposure to our patients, our staff, and ourselves. Distance from the source. The more distant we are from the source, the less radiation for ourselves. Beam orientation, the less complex our projections will be, the less radiation to the patient and to ourselves. Collimators, the use of collimators. Use pulse, low pulse rates as opposed to high pulse rates. And more important, compliance with the dosimetry badges that we always have a rough time complying. So I believe that the physician procedure conduct should be determined. A physician should strive for lowest dose and rate possible without compromising image quality and procedure efficacy or procedure results. This is obtained obviously with education. Now quickly we'll change gears again to the shields available to us, or the tools available to us to protect ourselves from radiation. We have traditional shields on wheels or bedside. We have lead aprons. We have obviously apparel that includes eye protection and rad pads that we can place at the patient's bedside to reduce scatter radiation. We have cabins that are very efficient, but I imagine very difficult to use and very cumbersome. We have suspended systems, which are our favorite shielding system in our hospital. Suspended systems that are, for multiple reasons, is our favorite choice. Number one is cost effective. Number two is very easy to use. And number three, all physicians like it. The old geezers like it, the young snappers like it, and the ones in the middle like me like it. We also have obviously navigational systems that allow us to manipulate catheters in the cardiac chambers without having to use significant fluoroscopy. We have also intracardiac echo, allows us to obtain structures of the heart and moving catheters within the heart without having to use as much fluoroscopy. We also have robotic systems, whether magnetic or remote steerable devices, that's available to us. So now I'm supposed to predict the future. I wish it was as easy as taking this turn and following this arrow and this sign. Obviously, the future we think is all about protection. And we say is all about protection because we have not paid attention to protection enough. We're paying a lot of attention to technology, how to improve penetration, how to improve imaging, but we have not paid enough attention to radiation protection. And I think it's very important to avoid headlines like this, where there's obviously a significant, clear association, brain tumors with radiation exposure. I don't think that we should be spending energy anymore in showing causation. I think we should be spending our money and time finding ways to protect ourselves, because our colleagues are dying because of radiation exposure. So the future, I think we need to do better education, advanced training. We probably will require certification maintenance in some hospitals. We will probably include in the informed consent some way explain to the patient the radiation exposure hazards. Develop QA programs that will evaluate dose control techniques. And this is not a Photoshop. This is a real picture taken in our lab about 2 years ago. This is an attending physician showing a cardiology fellow how to do an angiogram, and as you can see, not protected, believing that he has enough protection by just standing behind the cardiology fellow. I think also we'll have to improve records and record keeping. We'll have to document obviously the dose, and the dose will have to be reported in an electronic system so that it can be carried on to medical informatics. We need better protection, and I predict that better protection will be provided by mostly real-time dosimetry, visual close monitors, and suspended shielding systems. Why real-time dosimetry? It provides you obviously a proactive approach, not a retroactive approach. The current system now, dosimetry, if we wear them, we will get a report about 6 months later telling us about our dose exposure. This is a real report that I received just a few days ago on our radiation exposure to some of our personnel in our lab. I think I show here there is 2 individuals there that received way too much radiation, exceeding the state reportable limits. This letter is from March 12th. That radiation exposure is from the 3rd quarter and 4th quarter of the year before. Too late to teach a cardiology fellow how to change their behavior. These cardiology fellows are 3 months from graduating. So this system is obsolete. It needs to be changed. Why visual monitoring? As I described, it provides you real-time evaluation of what's going on. It gives you a visual image of immediate radiation exposure to your personnel. And I have a picture here of how one of the systems would work. You would wear a electric or electronic badge that would communicate with the monitor. The monitor would be displayed next to your fluoroscopy image, and you would know who is being exposed, and then you would have the opportunity to change your beam, change your pulse rate, etc. And finally, why suspended shielding? Because there's plenty of evidence showing that suspending shielding is much better than our traditional shielding, and it's very cost effective. This data obviously has been reported many ways, but I picked this particular slide showing to you how the reduction in radiation, in this particular protocol published, it was radiation to the left eye, speaking of left brain tumors. The reduction in radiation was up to 95%, and these procedures were performed from the femoral region, thoracic region, and cranial region. In summary, we have seen major advances in radiation technology. Ionizing radiation is an important diagnostic and therapeutic tool, but must be used with caution. Ionizing radiation exposure is a constant health hazard, especially with our current complex and repeated interventions, for example, AFib ablation. Over the years, we have failed to take the hazard seriously. Complacency and burden of use of many of the equipments that we use to protect ourselves probably are the most important factors why this has happened. Continual education and performance improvement will hopefully help develop strategies to change our behavior. A dialogue in between, industry, regulatory agencies, and hospital to trigger meaningful policies and protocols. And real-time monitoring, suspended shields will be probably the new game changers in this arena. If I have time here, this is a map of the Metro Detroit area for those of you who are not familiar with this. And these little stars I show you here are actually cases that I know of electrophysiology physicians who either passed because of brain tumor, one, another one, thyroid tumor that actually put them out for 2 years, and the other ones are actually physicians who retire before the age of 55 because of chronic back pain problems, and this is real. This is a picture of squamous cell, or I should say basal cell carcinoma, recently published in the Interventional Journal of Cardiology, a case of an interventional electrophysiologist with 5 squamous cell lesions. I myself, I share that with you, I've had 2 removed from my face, and I believe that obviously have to do with the lack of protection against radiation. And this is it. I'm open for questions.
How about a nice thank you for Dr. Machado?